Welcome to our live stream, Updates in AL Amyloidosis, Fast Forward in 2024. Thank you for joining us. My name is Ryan and I'll be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this live stream technology. At any time, you may adjust your audio using your computer volume settings. On the right-hand side of your screen, you will see the audience engagement window with navigational tabs at the top. The Q&A polling tab is where you will ask the presenters questions. You will need to enter your first and last name to participate in polls or to ask a question. To ask a question, click in the text box and type your question. When finished, press the Enter key or click the paper airplane icon to send the question. All questions that you submit are only seen by today's presenter. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. We are joined today by our speaker, Heather J. Landau, MD. She is an associate attending physician on the adult bone marrow transplant, cellular therapy, and multiple myeloma services at Memorial Sloan Kettering Cancer Center and is the director of the amyloid program. She is also an associate professor of clinical medicine at Weill Cornell Medical College. I'll now hand it over to Dr. Landau.
Thank you so much for that kind introduction and for this opportunity to share with you updates in AL amyloidosis, fast forward in 2024. It is a privilege and pleasure to be here today. Today, we're going to review the pathophysiology of light chain amyloidosis and the goals of treatment, discuss strategies that are being studied to facilitate early diagnosis, describe standard approach to the treatment of AL amyloidosis and the rationale to incorporate immunotherapy, discuss how the treatment landscape has changed based on the recent advances, and highlight novel immune and cellular plasma cell-directed therapies, as well as antifibrillar and light chain stabilizing treatment. So light chain amyloidosis is a complex disease characterized by the production of light chains by bone marrow plasma cells. This cartoon depicts pathologic plasma cells that proliferate in a monoclonal fashion, meaning that all of these plasma cells are of one type, where plasma cells typically produce antibodies made up of heavy chains and light chains. It is these freely circulating light chains that misfold into amyloid fibrils and deposit in various organs. The monoclonal free light chains are measured by the serum free light chain assay. Here I show the common organs affected by light chain amyloidosis. You can see in the upper right corner periorbital bruising and macroglossia. While these are pathognomonic for AL amyloid, these symptoms occur in less than 25% of patients. More commonly, patients present with cardiac or renal involvement. Cardiac disease manifests as heart failure with preserved ejection fraction, cardiac arrhythmias, dyspnea on exertion, hypotension, syncope or edema, and renal disease typically presents with proteinuria. GI involvement can lead to malabsorption or weight loss or GI bleeding. Liver involvement is usually marked by an increase in alkaline phosphatase or a large liver. Peripheral neuropathy typically presents as a sensory neuropathy with numbness, tingling, or pain in hands or feet, or autonomic dysfunction, which can lead to orthostasis or postural hypotension, erectile dysfunction, or GI motility issues. The result of having one or more organs involved with amyloid is that patients present with nonspecific symptoms that often mimic more frequent conditions. This is problematic because patients are sent to multiple specialists who don't often recognize that the patient has amyloidosis before ultimately making the diagnosis. In fact, in a survey we did a number of years ago, already that included over 400 patients and their caregivers. They actually named 223 cardiologists that missed the diagnosis, who missed the diagnosis. And this leads to a substantial proportion of patients who have symptoms and suffer for a year or more before their diagnosis. We recently looked at the time to diagnosis based on the number of both symptoms and systems involved. And indeed, either having more symptoms or systems involved was associated with longer time to diagnosis, while having fewer symptoms or system led to a speedier diagnosis, likely because, again, all of these patients were sent to multiple specialists before achieving a diagnosis. So the goal of treatment, once the diagnosis is established, is to target and eliminate the pathologic plasma cell, which is the factory producing the pathologic light chains. And when we do, we can see the circulating light chains in the blood decrease, and this is measured by the serum free light chain assay. And with anti-plasma cell therapy and reduction of the free light chains, organs can improve. And we measure those by some of these biomarkers shown here, NT-proBNP in the case of the heart, or proteinuria in the case of the kidney, or alkaline phosphatase in the case of the liver. And having both a heme and an organ response is associated with the greatest likelihood of achieving a longer survival. And a better or deeper hematologic response is associated with a higher likelihood of an organ response, again, which has an impact on survival. What does treatment look like in 2024? Previously, anti-plasma cell therapy constituted alkylators, stem cell transplant, proteasome inhibitors, steroids, and immune modulating agents. But now, daratumumab, which is an anti-CD38 antibody that targets pathologic plasma cells, was developed initially for multiple myeloma patients, but was shown to be effective in light chain amyloid. So this Andromeda study was designed, which included almost 400 patients, who were newly diagnosed and were randomized to the combination of bortezomib, cyclophosphamide, and dexamethasone with or without daratumumab for a total of 6 cycles. And in the daratumumab arm, there was maintenance with monthly treatment. This was designed to test the primary endpoint of complete hematologic response. And here are the initial results with over 11 months of follow-up, that the complete hematologic response in the daratumumab arm increased, essentially tripled, versus those who did not receive daratumumab. And you can see here that also the cardiac responses and renal responses nearly doubled. And this led to Dara-VCD as the first and only approved drug regimen for AL amyloidosis. So what are the implications of the Andromeda trial? Now Dara-VCD is really used as initial therapy for all newly diagnosed patients with AL amyloidosis. It's really our new standard of care. With longer follow-up, the hematologic CR rate in the Dara-VCD arm is 59% versus it has increased with time versus 19% in the VCDR. And this hematologic complete response rate is really comparable to what we see with stem cell transplant plus consolidation. And so this has led to the role of stem cell transplant being questioned. And there's two schools of thought. Number one, DARA-VCD has increased the CR rate and led to increases in organ improvement. And some folks in the field think that this will indeed lead to more candidates being eligible for stem cell transplant because patients will get better and have less comorbidities and be able to undergo a stem cell transplant. And this thought is because we have such good data with stem cell transplant being used in this patient population and have shown that people who achieve a CR to stem cell transplant really have excellent outcomes, while there is still no long-term data with DARA-VCD. So that speaks to some of the folks in the field really arguing for continuing to offer stem cell transplant, whereas there's another school of thought that DARA-VCD increases the CR rate and leads to organ improvement and actually may limit the amount of stem cell transplants to those who have a suboptimal hematologic response. So there is a clinical trial that has recently opened to understand the value of stem cell transplant in the setting of DARA-VCD. And this is a randomized trial where patients who are potentially eligible for stem cell transplant will be randomized after 3 cycles of DARA-VCD to stem cell transplant or DARA-VCD, and both arms will receive DARA maintenance. So in terms of salvage treatment options in AL, there's actually no standard of care. Again, DARA-VCD is the only FDA-approved treatment regimen for this condition, whereas we used to use and have studied all of the drugs listed here, which are commonly used in patients with multiple myeloma. These were uniquely toxic to patients with AL amyloidosis who really have different pathophysiology. So we are very excited that now in 2024, we have available and are studying targeted therapies, immunotherapies, CAR T cells, and amyloid-directed therapies. And with these new therapies, we do have to understand that there's unique toxicities, and similar to in the past, studies in, we can't just adopt these therapies from patients with multiple myeloma without studying them in the AL amyloidosis patient population, again, because patients typically have unique pathophysiology. So venetoclax is actually the first targeted therapy for AL amyloidosis, and it's an important therapy because 50% of patients with AL have the cytogenetic abnormality translocation 1114, and this having that translocation in your plasma cells renders patients uniquely responsive to this BCL2 inhibitor. And this has been looked at retrospectively when patients received this drug, and the first publication showed that there was a very promising hematologic response rate in 27 patients who received this drug alone or in combinations. And while it It is not FDA approved for this condition. Several clinical trials are ongoing or planned, and many of us think that this is a reasonable second-line treatment for patients with translocation 1114 because of the high response rates and overall well tolerability of this oral agent. Where do chimeric antigen receptor CAR T cells come from? This has been a groundbreaking approach, really, in the treatment of a wide variety of hematologic malignancies, and the impressive efficacy of BCMA-targeted CAR T cells has led to the FDA approval of 2 products in patients with really heavily pretreated relapsed and refractory multiple myeloma, with response rates that have been unprecedented in this patient population. And we do know that BCMA is also expressed on amyloidogenic plasma cells and also retained at relapse. So how do CAR T cells work? Well, the patient has what we call an apheresis, where peripheral blood lymphocytes are collected either through a vein or through a catheter, and the T cells are separated from that and taken out of this collection. And then this chimeric antigen receptor, which is engineered to target a specific antigen, is then introduced to these lymphocytes that are then expanded in ex vivo or outside of the patient and then infused back to the patient. And these, so the patient gets their own lymphocytes that have been engineered to have this receptor that will target a specific antigen on the pathologic plasma cell. You can see here when this CAR T cell targets in this case, BCMA on the pathologic plasma cell, it results in plasma cell death. Again, with this novel immunotherapies or cellular therapies, there are new unique toxicity profiles, including, most importantly, CRS or cytokine release syndrome, immune effector cell neurotoxicity or ICANS, and there's also the possibility of infections or also longer term. We also see some cytopenias. So the first CAR T cell, BCMA-directed CAR T cell that was used in patients and used and reported in patients with AL amyloidosis comes from an academic medical center in Israel, where they designed a trial of this BCMA-directed CAR T cell, really for relapse refractory myeloma, but this was one of the only clinical trials that allowed for the inclusion of patients with AL amyloidosis. And in this bigger clinical trial that again was really designed for patients with relapsed refractory myeloma, there were 11 patients with AL who were treated at a variety of doses seen here, and this was initially presented at in 2022 and recently updated at the American Society of Hematology meeting last December in 2023. And this group showed the safety of this product in patients with AL amyloidosis, while almost all of the patients did experience cytokine release syndrome, which manifests as fevers or hypotension or hypoxia. Most were grade 1 or 1 and 2 and very manageable with drugs that target the IL-6, and which is the cause of this cytokine release syndrome. And in the 10 patients who were evaluable for response, they showed a very promising overall response rate of 100%, including 60% CRs and another 30% with VGPRs, as well as also very good organ response rates in this patient population. And so this trial really allowed us to understand that plasma cells from amyloid patients really express sufficient BCMA for clinical targeting. The 11 patients that were treated safely, and quick and deep light chain reductions with this therapy really led to organ responses. And I'm happy to say that we are now studying this product for patients with AL amyloidosis, specifically in a phase 1b dose expansion trial, where we're including patients after first-line therapy who have had less than a VGPR, or patients in the relapse refractory setting, doing several different correlative studies. And this trial is actually open and enrolling at MSK. So hopefully more to come with CAR T-cell therapies in patients with AL amyloidosis moving forward. There's been several other immunotherapeutic approaches that have come to the forefront at this point, and belantamab mafodotin is an antibody drug conjugate that is directed against BCMA. And so this drug is an antibody that delivers a cytotoxic payload, meaning when it binds, in particular in this instance, the drug cystatin F is delivered to the plasma cell and leads to plasma cell death. In specifically AL amyloidosis, there's been few retrospective series reported, and one prospective trial is underway. In the initial experience, again, in small numbers, the overall response rate and VGPR and CR rates were promising. This product also has unique toxicities that really this causes something called keratopathy, or blurred vision, in up to 80% of patients, which can be obnoxious, but it is at least reversible. And we are we're studying ways to mitigate this toxicity moving forward. Bispecific antibodies is another unique immunotherapeutic approach, and I show here this antibody. There's an antibody that one side of the antibody targets the T cell and the other targets an antigen on the pathologic plasma cell. And again, this brings together the T cell and the plasma cell, leading to plasma cell death. And this was very successful in multiple myeloma and has led to 3 FDA-approved products for patients with heavily pretreated or relapsed refractory multiple myeloma, with, again, really promising response rates. These drugs have a similar toxicity profile as the chimeric antigen receptor CAR T cells, because again, it's what we call a T cell redirecting therapy. So CRS, ICANS, infection are common after these products, but we are learning ways to manage these very effectively. So the first report of using a bispecific antibody against the BCMA target was recently published, with 7 patients. All had achieved at least a VGPR to this drug, teclistamab, and very quickly, in less than a month. So again, this These drugs are being studied in clinical trials in patients with AL amyloidosis and will likely play an important role moving forward. Here I just show one of the drugs, ABBV 383, that has opened the phase 1B clinical trial where there's a dose escalation phase, and then we'll be expanding this drug on 2 different doses. The unique thing about this drug, which is more user-friendly because it is once a month dosing, which is really nice for patients with who are coming back and forth to the center. But hematologic response is not necessarily a guarantee for organ response. And I just wanted to highlight a clinical case where we treated a patient with amyloidosis with a stem cell transplant. I want to orient you. This is a measurement of her free lambda at the time of diagnosis, where she, in 2008, when she received a stem cell transplant, and you can see that post-transplant, the value of the free lambda didn't change much. So she did not achieve a hematologic response, but with Velcade and Dex as consolidation, she quickly achieved a hematologic response and remains in a complete hematologic response to date. So this is somebody who was treated in 2008, didn't respond to a stem cell transplant, got Velcade afterwards, and remains in remission now 16 years later. So patients who achieve a good response can stay in a good response even without ongoing therapy. So this is a patient who has kidney involvement with amyloid, and you can see here her disease manifested as significant protein loss in her urine up to 21 grams at its peak. And although she achieved a complete hematologic response in 2008, it wasn't until 2014 till she had reduction of her urinary protein excretion to less than 1 gram. So when I say that urine organs take time, we can achieve complete hematologic response quickly, but that doesn't mean that the organs improve quickly, and it really takes months to years for organs to respond. She actually now, since 2018, has no detectable protein in her urine, but it really takes months to years. You can see here when she's losing all that protein in her urine, the protein in her blood was quite low, and it actually took 4 years to normalize. So organ responses take time, with the median time to best renal and cardiac responses 29 and 24 months respectively. So you have to be a little bit patient. And supportive care is essential for patients, because even if they achieve a complete hematologic response, they still need to be supported. So this is the reason why amyloid-directed therapy is being developed, because all of our standard of care treatment targets pathologic plasma cells, but does not address the amyloid that's already deposited in the tissues. And if we can develop effective agents to target amyloid fibrils and for removal, then perhaps we can hasten organ improvement or prevent organ deterioration. And here I show 3 different antibodies that have been developed to target amyloid fibrils or their precursors that are circulating in the blood. And bertamimab was the first developed. It showed promising responses initially, and a phase 3 study was stopped early because there didn't seem to be any benefit. However, there seems to be a subset of patients who may benefit, and that's now being studied in a randomized trial. And Solemimab is another one of these antibodies that, again, had great preclinical data and initial responses shown in the phase 1/2 study and is now being studied in patients with advanced cardiac disease in 2 phase 3 trials, and we eagerly await the results of this drug. And a third, ATO2, is being studied in Australia to see if, again, we can improve patients' organ function quicker than just by targeting the plasma cells. Light chain stabilization is another mechanism to target, to improve or prevent organ deterioration. And if you can see this cartoon, that actually these monoclonal light chains have a specific conformation and then unfold in order to refold to form the amyloidosis. So if there is a way to prevent their unfolding by stabilizing their conformation, we can potentially prevent the unfolding and misfolding and prevent the deposition of amyloid fibrils. So small molecules that are kinetic stabilizers by binding to the light chains in their normal conformation to prevent misfolding, cytotoxicity, and aggregation of amyloid fibrils are being studied, and we await these results of this type of drug development. So even when we achieve a complete hematologic response, sometimes organs still fail. And in that setting, we are studying organ replacement. This is some data from a single center where cardiac transplants were performed in patients with both AL and TTR amyloidosis, showing really very good overall survival. That's the follow-up is short, but this is comparable to cardiac transplants for other conditions. Similarly, patients who have renal deterioration despite having hematologic response and require renal replacement therapy or dialysis often need organ transplant. And while in the past there were several single centers series that were reported, recently we reported on over 200 patients from an international experience of 5 different countries, and showed that patients who have AL amyloidosis and get renal transplants do very well, with a median overall survival of over 8 years, especially when they have a good hematologic response when they receive their organ. On the right here, you can see that with each decade, because this was a study that spanned from before 2000 to 2020. With each decade, we are having more patients go to renal transplant, and a more frequent number of patients who achieve very deep responses given the availability of better therapies. Even in patients who relapse despite getting an organ transplant can be salvaged. So amongst 30% of patients who relapse or progress, really only 6 patients in our full series had allograft failure from amyloid recurrence. So really in patients with CR or VGPR, if you achieve a hematologic response, but the organ doesn't improve, or you've already been on hemodialysis, I think it's really important for patients and physicians and renal transplant physicians to understand the value of renal transplantation in this patient population. In fact, this led us to recently host a symposium on kidney transplantation and plasma cell disorders at MSK. And this was for, we invited physicians from all specialties, including general nephrologists and transplant nephrologists and the hematologists, to educate one another on all of the advances in plasma cell disorders so that the renal transplant folks can really consider these patients for renal transplantation, which is really life-changing for our patients. In conclusion, standard of care treatment for AL incorporates the monoclonal antibody daratumumab. And that has really changed the treatment paradigm. This may increase or decrease the use of stem cell transplant in the upfront setting, and that's currently being studied. Organ responses take time, and persistent organ disease is not an indication to continue or change therapy when patients have achieved an optimal hematologic response. Other immunotherapeutic approaches, including BCMA-directed studies in the salvage setting, are ongoing and planned. These have unique toxicity, which we are getting better at managing, and I would argue that are very manageable. Directly targeting amyloid deposits or stabilizing light chains are strategies that are being studied to reduce organ dysfunction or hasten organ recovery. We eagerly await results of the clinical trials that are ongoing. And then patients who have advanced organ disease and have achieved a hematologic VGPR or CR really may be candidates for organ transplantation and should be considered. But nothing replaces the importance of early diagnosis, because when patients present with ongoing symptoms and are missed for months to years, they are harder to treat, and it is much harder to reverse the organ damage that has already been done. And it is also critical for patients to participate in clinical trials, because that is the only way that we can get FDA approval of all of the promising drugs that we are studying. And that's the only way to get these drugs available to the most, to the patients who are out there. But the future is bright ahead, and I look forward to continuing to update you with all of the progress that's being made. Thank you for your attention, and I welcome any questions.
All righty, thank you very much. We are now moving into our live Q&A portion. And Dr. Landau, I'll hand it back over to you.
Thank you so much. So I'll read the questions out loud and respond. Feel free to continue to put questions in the chat. The first question is, how many amyloid depletion drugs are in trials now? 3 of them. The bertamimab is being developed by Prothena, and the Calum drug is being studied into phase 3 clinical trials, and then there is a drug being developed so far only in Australia. Which one of the amyloid depletion drugs is most promising going for FDA approval for clinical use? I think, just like everybody, I'm eagerly awaiting the results of the clinical trials. I don't have any data until the trials are unblinded and we see what we see. Does it make a difference what my what protein-rich foods my patient eats. Should patients have more protein meals, or is less better? Really, our bodies handle protein very differently. I don't think even if you have, I'm assuming this is coming from somebody who takes care of patients with nephrosis or proteinuria. Unfortunately, you can't really counter that by eating enough protein, and you don't really hurt your kidneys by eating too much protein, because our bodies are good at regulating that until they have a sick glomerulus that loses the protein. So it's kind of a well-balanced diet. It doesn't, the diet itself, I wish, could make a huge difference, but it really doesn't. What organization sponsors CAR T in refractory AL amyloidosis clinical trial? I think, as I said, we are currently accruing to a BCMA-directed CAR T cell trial that is sponsored by Nexella. There are other companies that are interested in developing CAR T cells in this space, but those studies are not yet available. Can any of these be used with LF2 amyloidosis affecting the kidneys? Unfortunately, the plasma cell directed therapies are not expected to be effective in patients with LF2 amyloidosis. However, the antifibril antibodies may in some way be agnostic to the type of amyloid being deposited, although that needs to be studied in clinical trials. Is AL amyloidosis being diagnosed with greater and wider occurrence? I think that we have benefited, the AL population has at least in part benefited by the TTR population, because really the explosion of new drugs in the transthyretin amyloid population, there is a lot of marketing going on to get patients diagnosed such that they can be treated. So there's now pharmaceutical company interest in marketing to cardiologists and the potential TTR patients. And because there is some overlap with the demographic of patients with TTR and MGUS and potentially AL amyloidosis, I do think we're doing a tiny bit better at recognition, or a very tiny bit, but I would say that a huge important effort still, and a big unmet need, is really educating the community about recognizing AL amyloidosis and diagnosing it. How to best deal with an MRD positive after a complete heme response. That's really controversial, because patients who are MRD positive but have organ improvement probably don't need any additional treatment. Yet we do know patients who get into deeper responses in the myeloma population, and at least there's some data in the amyloid population that they have better outcomes. So, but when we know that in population studies, but we don't know that making somebody who is MRD positive into MRD negative will change their outcome. It's a little bit complicated. So it really depends on individual circumstances. What's the timetable for results from KALE 101? The company has committed to unblinding the study 18 months after the last patient in, which falls in February of 2025. So hopefully we will get results at that time point. How do we focus on organ improvement? I think that two ways. Number one is diagnosing this disease earlier before there is advanced organ deterioration. And number two is maybe these anti-amyloid or anti-fibrillar antibodies or other strategies similar, or light chain stabilizing drugs, other things that can preserve organ function, as well as all the supportive care management and efforts that are very much important for our patients. Is there any drug in trial looking at GI improvement? That is a great question. Unfortunately, I do not know of any drug that is specifically looking at GI improvement in AL amyloidosis. With a heme CR, should stem cell transplant be considered at all, considering other non-transplant options? That's a great question, and we don't have the answer to that. That's why we're doing the clinical trial, where we're randomizing patients to who have achieved a response to DARA, CyBOR-D, to continuing that or getting stem cell transplant. We just don't really know if there's any value in. There's a whole wide range of people who believe different things, that sometimes, it is likely that we'll get deeper responses with transplant and outcomes are really good. But on the other hand, we may cause toxicity with stem cell transplant. And if you're already in a heme CR, it's hard to know what the value is. So that question will only be answered in a randomized clinical trial. There's some questions that are very specific to certain patient situations, which I am not going to answer, but of course you can follow up with the Amyloid Foundation, and if I could be of any help, I'd be happy to. But I'm going to go ahead and read the more general questions. How would you recommend encouraging a patient to be medication compliant after receiving therapy and achieving a hematologic response? That's a tough one. Also, I don't know if that means supportive medications or continuing on chemotherapy or daratumumab. The truth be told, in terms of daratumumab, we don't know how long is the length of continuing on treatment once you've achieved a hematologic CR. Do the genetic changes in AL carry the same prognostic weight as standalone myeloma? Actually, that's a great question. There's the genetic changes that we see in amyloid are actually somewhat different than what we see in myeloma, such that translocation 1114 we see in 50% of our patients with AL, and only 25% in patients with multiple myeloma. It had been thought to be a unfavorable characteristic in patients with AL amyloidosis, but now that we have good drugs to target this translocation, there is really good outcome. So things kind of change over time. I think the highest risk cytogenetic abnormalities like deletion 17p still are unfavorable in patients with AL amyloidosis. When facing the decision of stem cell transplant, what resources would you recommend the patient considers? I think speaking to your local physician, your transplant physician, and support groups like the ones provided, the support systems like from patient advocacy groups like the Amyloid Foundation or Amyloid support groups, or local support groups would be a great service, or a social worker. Can therapies discussed here be used to treat ATTR cardiac amyloidosis? Again, the plasma cell directed therapies are not transferable to ATTR. Whether the antifibrillar antibodies may ultimately be transferable, I think remains a question, but is certainly a possibility. Is there a specific blood test that will detect this other than a biopsy for early detection? I think we're all working on that because there are some suggestions that there are genetic components of the light chain that may indicate an amyloidogenic light chain, even in advance of having clinically significant disease. But that's not really ready for prime time. But the serum-free light chains or the serum protein electrophoresis are indications that are can be supportive if you are suspicious for an amyloid diagnosis, but really we need tissue and a biopsy. Is anyone systematically collecting data on long-term survival with AL? I think there's a lot of us who are looking at that, and there's been several published series, at least two that I know of, one from the Mayo and one from the BU group, that shows long-term outcomes in patients with AL. I've listened to several webinars at this site from which I gleaned useful information, but this presentation seemed to be mainly for healthcare professionals. Will there be a presentation that can be more easily understood by the general population and parents of AL patients? I'm sorry that this was kind of a higher level, but there are definitely opportunities for more patient-focused and information from places like the Amyloid Support Group, other webinars that have been done for Amyloid Foundation, and I think Amyloid Research Consortium as well. And any questions that you are still struggling with, please ask the Amyloid Foundation to reach out. In cardiac amyloidosis, do the AL fibrils become fibrosis over time and result in irreversible loss of function? Yes, so that is a great question, and one we don't really know the exact answer to. I think that we all see that in the kidney and the heart, there does seem to be fibrosis over time, and it may ultimately lead to irreversible loss of function. Mostly in the heart, I would say. The kidneys recover, but not because when there's proteinuria, the kidneys can recover, but that's because it's, I believe that the kidney compensates, not necessarily reverses the fibrosis that occurs. And that's when the disease is primarily affecting the glomeruli. Is DARA used as a maintenance drug for relapsed AL amyloidosis? For relapsed AL amyloidosis, it's been studied as a single agent and in combinations. And the first study that reported excellent results was a study where daratumumab was given monthly as maintenance for a total of 2 years. What does free lambda mean, specifically the word free? So the plasma cells are a cell that are immune cells or infection fighting cells, and they make antibodies. And an antibody is made up of one part is a heavy chain and one part is a light chain. So every antibody has these two parts, heavy chains and light chains. And it's the light chain portion of the antibody that is no longer attached to the heavy chain portion of the antibody and circulates freely. That is the entity that misfolds into light chain amyloidosis. So free means that the light chain, as opposed to the light chain attached to the heavy chain, circulates free and has the capacity to misfold into amyloid fibrils. Is there any research tracking with respect to toxins causing AL, for example, patients who were present during 9/11? That is a great question. There are a lot of work being done for 9/11 survivors. Unfortunately, as all things amyloid or AL amyloid go, the public or private sectors are always much more focused on myeloma, the other plasma cell disorder, because the incidence and prevalence is much higher. So there has been few studies, at least in the 9/11 population, looking at the direct toxins that lead to AL amyloidosis. That seems to be all of the questions I see right now. If there are no more, I appreciate everybody's time. I'm happy to answer anything through the Amyloid Foundation moving forward, and hope to participate again soon.
On behalf of the Amyloidosis Foundation and AstraZeneca, I would like to thank you for your participation in today's event. This concludes today's stream. Thank you and have a great day.